cheek. The cheek corresponds to the space between the zygomatic arch and the malar bone at the top and the mandibular arch at the bottom. It does not correspond to any bony structure. It extends horizontally from the region next to the nasolabial fold to the preauricular region, which is a basically fixed structure given the presence of fascia and ligaments. Thinning or lipoatrophy of the cheek is the result of the loss and sagging of adipose compartments. Superficial medial cheek fat, superficial middle cheek fat, and lateral temporal cheek fat located further towards the back, associated to a lesser extent with the activity of the peribuccal and masticator muscles. A specific anatomical entity is involved in the jugal anatomy. Bichat's fat pad, essentially developed in children and found in the superficial buccinator muscles and deep cheek masseter muscles. The loss of volume in Bichat's fat pad leads to the hollowing of the cheek. The main anatomical precautions for the jugal injection involves the buccal branches of the facial nerve, which extends from the deep anterior limit of the parotid gland to the superficial peribuccal region, and the facial pedicle, which passes in front of Bichat's fat pad. Bordered by the zygomatic arch of the cheekbone at the top and the mandibular line at the bottom, filling the cheek may be done using many different techniques based on the indication, facial physiognomy and the patient's wishes. For the most common case, we will choose a netting or grid technique with 2 crossed fans, allowing to fill and smooth out the thinned jugal zone. The first insertion point, at the top rear, corresponds to the lower edge of the zygomatic arch. Fan provides filling from the lower edge of the zygomatic arch in the direction of the anterior and lower limits of the jugal fold being treated. The second insertion point, at the bottom rear, corresponds to the mandibular angle. The fan provides complementary filling and sustension of the jugal fold in the direction of the anterior and lower limits of the jugal fold being treated. After disinfecting, make a pre-hole with a needle to the dermic-hypodermic junction and insert the cannula parallel to the cutaneous plane in the desired injection plane. Make the retrotracing injection by removing the syringe to obtain a linear and homogeneous Radiesse deposit. Without removing the end of the cannula from the skin, change its direction and inject as many new lines as needed. The adjacent product lines are fanned out while limiting the number of injection points. Massage and shape the areas injected to evenly spread the product. With Radiesse, the product deposit and correlated correction are assessed immediately. Several fans can be combined, ending with a netting or grid technique if volume restoration requires it.